in the absence of really addressing that as one of those fundamental upstream drivers, we are going to continue to struggle.
And Mr. Thiessen, you want to add on that?
Yeah, that's a very good question, and that is a huge driver right now in society in general, right? And for me, stigma and shame go hand in hand, right? I notice and it plays both sides, right? Right now, there's a huge stigma towards recovery, right? And I've had a lot of people, when I was addicted, stigmatize me and everything, and the way I see it now, and the way I speak to people that are on the cusp of entering recovery and everything is other people's opinion is really a rotten way to live your life. It's your opinion about yourself, and I think changing the societal shift in how every aspect of a recovery-oriented system of care is viewed shouldn't be stigmatized. It's hurting more than anything right now, right? Shame is a huge feeder of addiction, so and those coincide with each other.
Thank you, Mr. Thiessen. Suite, Monsieur Lemire, pour 2 minutes et demi.
Proceeding with Mr. Lemire for 2.5 minutes. Thank you, Chair. Dr. Drouin, can you talk to us about the regulatory obstacles that the federal government could remove in order to streamline the process to help community organizations and others to ask for and deliver exemptions for supervised controlled sites and for drug analysis sites, and especially why are these regulatory borders there? I will let Dr. Morissette answer this question. She manages all the bureaucracy. Yes. Here, the point is that we need to have an exemption to the Controlled Substances and Drugs Acts, whether for a supervised consumption site or a supervised inhalation site. We are at a point where we need to improve, increase, and diversify services, so we need less administrative burden in order to develop additional services, particularly for supervised inhalation sites. We know that there is we know that it's a very strict process. All partners are working hard to satisfy the criteria of the regulations, but to streamline the whole process would be a step in the right direction. Drug analysis is a must to fight the toxic drug crisis. Can you talk to us more about the efficiency of this kind of measure and what would be needed to make it even more efficient and effective? I'll start it off on this one. Drug testing has a lot of purposes. First of all, it allows drug users to assess the risk of the drugs they're taking. In addition, it allows us as public health authorities to test various drugs to see what exactly is on the streets at the moment, and then to be able to adapt our strategies for harm reduction as a result. As I was saying earlier, a lot of our sites are being diversified. We are offering drug testing in our supervised consumption sites, but we're also offering it in festivals. This is because young people go to these festivals and they often do drugs that could be contaminated. So we also use drug testing at festivals in order to prevent overdoses, especially because we're talking about occasional drug users here. Thank you, Dr. Drouin. Thank you, Mr. Lemire.
1.5 minutes.
Well, thank you. I think I'm going to ask Dr. Bach, can you talk about the Road to Recovery model and care at St. Paul's, and maybe just, I know some of the committee members have been there. I've been there to meet with you and your team and have a visit and better understand the work that you're doing. But you could talk about your model versus the alternative, versus, status quo to the alternative that you're delivering. And also, can you talk about the gaps and opportunities in the medical education landscape within Canada and how addressing these may also help to build our workforce for physicians to respond to this crisis with quality addiction care. You got about 2 minutes. I'll give you the rest of my time on this round.
Certainly. Those are two excellent questions. I already discussed briefly the Road to Recovery model at St. Paul's, and we were very happy to host some of these members there. And once again, we're talking about a coordinated model of care where essentially the essence of it is making, there's already a question here about forced treatment or coerced treatment. We have not traditionally done a particularly good job in Canada at making treatment easy to access, just easy to participate in, easy to access, easy to navigate, patient-centered, flexible, coordinated. Before starting more conversations about forcing people into treatment, I would suggest that we could start by trying to make it appealing and attractive and speak to people's individual needs and goals and situations and just make treatment easy. So again, the Road to Recovery program is about coordinating a whole host of services under one umbrella so that patients can enter at different points, can move through it in ways that that speak to their particular needs and their trajectories, which are seldom linear, as we know.
Dr. Bach, sorry to interrupt. Just do you think it's almost premature to even have that conversation about mandatory treatment when people who want help can't even get it anywhere in Canada?
I would suggest yes. I would suggest that we need to be focusing on making treatment available and easy for those who are asking for it, and that's a bare minimum of this. It's the bare minimum in terms from where we can start. Moving to your second question, which I think is a really critical one and one we don't talk about enough. One of my roles is as the director of our fellowship program here, which I'm very, very privileged to sit in, and we train 10 fellows per year approximately at St. Paul's. So that's 10 addiction medicine experts per year. Unfortunately, that's about a third of the capacity for the entire country coming out of our center. We simply do not offer a lot of training opportunities for people who are really seeking, if in the medical field, who are seeking to work in this space. And so when we're talking about increasing access to all these services, we really do need to to be mindful of our workforce and really look at ways of incorporating opportunities for education for any number of different health professionals, and really making that education available. In the current climate, anyone who is seeking further training or education in this space must be able to access that. Like that is if somebody's actively wanting to do this work, it's the least we can do to try and facilitate that exposure, that training, whatever level that might be. So in order to build that workforce, because
Thank you, Dr. Bach. Next, Ms. Goodridge, please, for 5 minutes.
Dr. Henry, I was wondering if you could tell us how many publicly funded treatment beds are in British Columbia.
I don't have that data, but I can get it to you.
The answer is 3,663. Sorry. Do you know how many people are prescribed safe supply in British Columbia?
The last we checked, the Prescribed Alternatives program had about 4,000 individuals.
So do you think that it's appropriate that there is easier access to drugs than to treatment?
I don't think those are in competition with each other. There are things that work together, as we've heard about. We need a suite of things, and people accessing pharmaceutical alternatives. We know that from the data, and I refer again to the report that I put out. We talked to a lot of people about this, and the most of the prescribed alternatives are being used in combination with OAT. So that is people being able to get into treatment.
What's the average wait time for someone to be able to get into detox in British Columbia?
Well, that would vary, and maybe Dr. Bach would be able to give you more details around that. But it varies, and one of the
Dr. Bach, if you can answer that would be great.
Certainly, it's going to vary tremendously depending on needs. Part of the Road to Recovery model has been streamlining that access. So for people who are deemed high priority, it's 24 to 48 hours for those who and certainly can be longer for those who there's a prioritization process. But for anyone high risk, youth, people high risk of overdose, generally within 48 hours in Vancouver Coastal Health at least.
According to the RCMP in British Columbia, nearly 2/3 of the detachment served communities do not have drug rehabilitation or treatment programs available. Do you think that's acceptable? Dr. Henry?
Of course not. We want access to treatment programs across the province, and we've been working to scale up that access as programs that Dr. Bach mentioned, for people to be able to access them anywhere in the province and have remote support, for example.
Do you think that decriminalization has been a success in British Columbia so far?
I think parts of it certainly have. With any change in policy that's like this, there are always unintended issues that come up, and we need to be pragmatic and address those.
So you think that having a record number of overdose deaths in the first year of a pilot project and having a premier beg the federal government to eliminate public drug use because it's been such a failure and people having to climb over needles to get to children's playgrounds is a success?
I'm not sure exactly what you're talking about, but I think we also have to recognize that long-standing personal, social, structural stigma that keeps people silent about their drug use and creates these barriers is not going to go away in a few months or even a year. So this is one of a suite of measures that we need to do to take away some of those barriers that allow people to reach out and connect.
Thank you. Were any studies done on the impacts of children seeing open drug use before the legalization project went into play in British Columbia?
I'm not sure what you're referring to. We don't have a legalization project.
Were any studies of public drug use on children done prior to going into this dangerous pilot project experiment?
I'm not sure what you're referring to, but one of the things that we do know
kids are being exposed to people that are overdosed on the street. They're having to climb past needles on playgrounds. Parents are having to sweep the Abbotsford soccer pitch on a daily basis because they are exposed to drugs. I'm asking, was anything done by the government of British Columbia to look at the impact of that on the development of our children before embarking on this project? Yes or no?
Let's think about this, because there is perceptions and stories that we are hearing, and we have not seen any data that there has been increased public drug use before and after decriminalization.
Do you have young children?
I do not.
Because parents are contacting me on a regular basis, telling me about how they have to sweep the playgrounds for needles and drug paraphernalia like crack pipes before they let their children play on community playgrounds. Do you think that's acceptable, yes or no?
Of course it's not acceptable. We all have concerns about public perceptions and public use. But this has not changed because of decriminalization of people who use drugs.
Thank you, Dr. Henry. Thank you, Ms. Goodridge. Next, Dr. Hanley, please, for 5 minutes.
Thank you very much. And I want to, I'm picking up halfway, so I'm going to apologize if I'm repeating any past themes. It's really good to be here. I'm going to concentrate my questions with you, Dr. Henry, and it's really good to see you again. I want to perhaps, since we're on this theme of public consumption and decriminalization, I want to allow you a little more time to maybe untangle what I see as a somewhat of a confounding between the idea of decriminalization and public consumption. I see public consumption every day in downtown Ottawa, for example, where there is no decriminalization. as yet. And so we know it's an issue that affects all of our inner cities and has long been an issue in Vancouver's downtown east side and elsewhere in BC before we came to this approach of trying to remove the stigma of criminalization from personal drug possession. So I'm going to allow you maybe a minute to really expand on this at your leisure.
Thank you. And I think that is the important thing. We have seen increased visible homelessness. We know that. We know that from data that across this country, as we've come out of the pandemic, we've had increases in people living in poverty, food insecurity, and that has led to being more visible homelessness. And some of those people are people who use drugs. So yes, I think it's very real and very concerning that we've had increases in people recognizing and seeing people on the streets. And that is hard for all of us. And that is something that is underlying some of the challenges that we're facing with increased challenges with drug use as well. So we do need to address that. I think to link it to one small policy change that is around removing criminal penalties for possession of small amounts of drugs is wrong. Because we know that this was a problem prior to that coming into play. It is still an issue that we all need to deal with. And we need to deal with the societal issues that underlie that, which is challenges with income insecurity, challenges with home insecurity and homelessness. And those are underlying issues that we need to work together on.
Thanks, Dr. Henry. You declared and I was one of your colleagues from in the Yukon, a CMOH, and I remember well when you declared a public health emergency in 2016. Can you give me a bit of a big picture view of where we are now compared to where we were then, particularly if we're thinking about how do we leverage further federal support, national coordinated support. I'm going to allow you to maybe give a bit of that big picture overview with a view to ongoing recommendations.
When we declared the emergency, and it was my predecessor who did that in 2016, it was really to raise awareness about this issue that was changing and changing rapidly and leading to people dying at an unprecedented level. And it allowed us to pull together information. It allowed us to start working on harm reduction. And if we think about it at the time, naloxone was a medication that was only available under prescription. So we have come a long way. We know that naloxone programs, take-home naloxone program, was started out here in British Columbia as a harm reduction measure, has saved thousands of lives. We were making some progress in putting together more coordination, understanding that pathway to treatment for people with a substance use disorder, raising awareness about the toxicity and the changing nature of the street drugs. And when we hit the pandemic, sadly, a lot of the supports that we had put in place that were making a difference in 2019, when we had the concerns about transmission of the virus, things got dramatically worse. But also during that period of time, the global drug trade got changed dramatically. The importation of small amounts of synthetic opioids really took over what we were seeing on the street, and that has remained at a very high level. But we have also made some progress, though the levels are still very high and too high. We have more awareness now. We have systems in place. We have programs like Hope to Health. We are now working at, finally, I believe, in our health care system to try and get a more cross-provincial support for people who have to enter into the health care system, because we know so much the stigma and shame that people who use drugs experience in our health care system. So we have these things, but we have to put them all together.
Thank you.
And we have to work in a coordinated way.
Thank you, Dr. Henry. Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. And back to you, Dr. Henry. Dr. Perry Kendall, he was BC's public health officer before you, 99 to 2018. Is that true?
He was the provincial health officer. That's correct.
And you seem to have some trouble with this, but the Vancouver Sun reported that in 2020, after retiring as the public health officer, he co-founded Fair Price Pharma. Is that true or is that not true?
He was involved with it. I don't know his exact nature. He was involved with it. He is no longer involved with it.
Right. I'm sorry, what did you just say?
As far as I am aware, he is no longer involved.
He was one of the co-founders of this company that imported 15 kilograms of heroin into Canada.
You must remember that any importation of drugs into Canada is done
Dr. Henry,
under
please,
Health Canada.
This is not your stage to grandstand. This is to answer some very pointed questions. So the questions would be is, you know, he was the co-founder of a company that imported 15 kilograms of heroin into this country. And the answer, of course, is yes. Do you know a Dr. Mark Tyndall?
I do know Mark Tyndall.
And is it true that he's the former executive medical director of the British Columbia Centre for Disease Control?
That's correct.
And former deputy provincial health officer under Dr. Kendall. Is that true?
That's correct.
And he started a company called My Safe Society. Is that true?
I don't remember the name of it. It could be.
Okay. Well, let's say it this way then. He started a company was to supply so-called safe supply harder morphone from vending machines. Is that true?
From biometric machines, I believe so, yes.
Fair enough. And that company then received $1.3 million from Health Canada's SUAP funding.
I'll take your word for it.
Well, thank you for that.
You're asking me for things that are not the details that I'm aware of or that I know of.
They're happening in your province, though, and you are the chief public health officer. That company also received $3.5 million in funding. Thank you for that. And that being said, are there other companies that you know of in Canada that have the dealer's license to legally possess, produce, sell, and distribute drugs such as opium, heroin, cocaine, and methamphetamine?
You would have to ask Health Canada that.
You are not aware of any of those companies?
This is not an area of my expertise. I
didn't ask you if you were an expert. I asked you if you were aware of any.
I imagine there are. I don't know. Those are not areas that I focus on.
So what you would tell Canadians is that you have no idea that these companies exist, even though many of them are located in your province.
I would say that all of the companies, and as part of my role as provincial health officer, I don't meet with industry, whether it's industry related to drugs or industry related to vaccines or any other thing. So those are not areas where I have detailed knowledge of companies.
Thank you. Dr. Henry, you recommended a non-medical model for safe supply. Do you have any examples of that you would have recommended to Canadians?
Well, we've been working on this, and I mentioned this when it's public knowledge when I came out with my report in February, that I think we need to look at all options around providing people with alternatives to what's toxic on the streets right now. And I have a report that we've been working on that will be coming out in the next few months on that.
Do you recommend compassion clubs like the one run by the Drug Users Liberation Front?
I don't recommend any specific model. I think we need to continue the conversation on what models.
You're okay with the Drug User Liberation Front, though? That would be a model that you would perhaps support?
I'm not supporting any specific models. I think we need to look at all of the options that are available that have the important regulations around them and support them.
Dr. Henry, to me it's very concerning that many individuals who were former officials of the British Columbia government, and indeed people have occupied your position, are now involved with distributing, selling, and dealing drugs such as meth, cocaine, heroin, etc., and profiting from it. Is that okay with you?
I don't. I think what you have to do is separate between legal use, and that is under the purview of Health Canada.
supporting these individuals. They did your job, and you're actually saying, hey, we should legalize more drugs in Canada. That's your pitch to Canadians. And oddly enough, these individuals are actually profiting from it. To me, that convinces me there's a significant conflict of interest here, Dr. Henry.
What I have always said and what I continue to say is that prohibition is one of the leading causes of the issue that we're in right now, and that legalizing and regulating is one way to manage the illegal and toxic drug crises that we're dealing with.
Dr. Henry and Dr. Ellis, we're going to give Dr. Pawlowski another try now that he's at a stationary location. Dr. Pawlowski, the floor is yours, unless we can't hear you.
Thank you, and hopefully you will. Okay, Dr. Henry, I'll continue where I was before. Certainly, I think the concern with Dilaudid is that it has become the kind of entry-level narcotic in Vancouver because it's cheap. And my understanding in talking to people who work in the community, the price of a Dilaudid one tablet was $20 before Safe Supply. Now it's $1. And as one psychiatrist said, he asks his kids who are on Dilaudid, why Dilaudid? And they say, well, on the street, it's $5 for me to buy a joint, whereas I can get 5 Dilaudid for the same price. So which are you going to do? And so certainly the concern is you start off with Dilaudid, and because, as you know, with narcotics, once you get used to it, you get tolerant, and you have to go to something stronger to get the same kind of buzz. So they're switching over to fentanyl. And certainly one psychiatrist who works with that population told me that if the kids he knows who are on is half are on Dilaudid, half are on, started originally on Dilaudid. So certainly there's the concern around Safe Supply. I don't know if you want to comment on that. And I think the Nguyen article in JAMA certainly suggested there was perhaps a societal harm that coincided with Safe Supply. But I don't know if you want to comment on that, but I want to go to the second part of the question, which is there is good evidence for...
Parlons des traitements antagonistes intraveineux où des patients reçoivent de l'héroïne pour une...
The sound quality is not good enough to allow for translation.
Bon, on me fait signe que c'est bon maintenant.
Oh, it was the wrong. Oh, okay. So it was a technical problem more so than a Dr. Pawlowski problem. Yeah.
Okay. So let me try to continue. Yep. So Dr. Henry, in your report, you also mentioned the fact that a lot of people who treat addictions were frustrated by the fact that Dilaudid wasn't really helping a lot of the real hardcore users who continued to use fentanyl, and they died from fentanyl. So given the success with IO, observed treatment, and given the possible concerns with diversion, why aren't we moving more towards directly observed treatment if necessary with intravenous drugs and getting away from going home with a bunch of Dilaudid like we're doing?
Well, I'll go to the second question first, because I think that is a really important thing, and that is one of the recommendations that came out of my report. And yes, injectable therapy is working for some people. It's very difficult to get into. There's very small number of access to programs. But we also know that people's use of drugs has changed over time, and people are not injecting as frequently. We know that smoking is the much more common way that people are using drugs now. So we need to have formulations that people are able to use in that way. And we've heard from people who use drugs that that's what they need as well, to be able to separate them from the toxic drugs that are on the street right now. We need to ramp up those programs, and my recommendations are that these start as directly observed therapy programs, but it needs to be accessible to people. That's the other problem that we have, that we can't prescribe our way out of this. So we have to have ways that people can develop those relationships with a clinic, clinic and I think the Hope to Health clinic is a good example of this, where they can get medications that they need to keep them on that road away from using the street drugs as much as possible and in the formulations that they need, and that it should be witnessed as a way to start. And then when you develop that relationship over time and that trust with people, because we also know that it's very difficult for people to stay in these treatment programs when they have to go in multiple times a day or every single day. And if something happens where they need to be with family or they miss their bus or there's something dramatic happening that day and they don't get their dose, that's when we know that people go back to accessing what they can find on the streets, for example. So absolutely, I think these are the things that and I've recommended that we look at how do we scale up access to prescribed substances that people need and will use. And that's another way of minimizing diversion, which is a symptom of unmet needs.
Thank you, Dr. Henry and Dr. Poloski. Suite, Monsieur Lemire pour 2 minutes et demie.
Merci.
Thank you, Chair. Thank you to all witnesses, by the way. Dr. Drouin and Dr. Morissette, when we meet with caseworkers on the ground, we often see that they say that if they want to mitigate the crisis, one way is to truly meet with drug users. Any action that would favor connection with them is a step in the right direction. In addition, services need to be accessible at the time that people need them. So that requires a 24/7 intervention capacity. Can you talk a bit more about that? Yes. When we talk about the full service continuum, we look at community groups who work on the ground and they build trust relationships with people, and they help clear the air about supervised consumption sites. There's also peer support available there. And supervised consumption sites are community services. And there are nursing services available on site as well that allow for additional health care to be delivered. Sometimes people are facing overdose, but they aren't going to ask because they've been hurt or they have another infectious disease or whatnot. These people, drug users, will be put in contact with specialized staff to help them with their drug use treatment as well. And this will essentially build a relationship of trust that will guide people toward treatment, yes, but on the other hand, also towards mental health services, housing services, and social reinsertion services. Our team includes additional caseworkers that look at evolving trends on the ground, cultural issues, and certain unique aspects that drug users have that will help our caseworkers work better on the ground. Yes, I'd like to say that on the ground in Abitibi-Témiscamingue, there was a team that carried out a study on psychoactive substances and RCMs in Abitibi. Un œil sur la réalité méconnue is the name of the report, and there is interesting data in there that I'm sure the committee would be interested in. Thank you. Thank you, Mr. Lemire.
Please, for 2.5 minutes.
Mr. Chair, before I get started on my time, I believe I have unanimous support to move a procedural motion that, pursuant to Standing Order 81.5, the committee invite the Minister of Health and Minister of Mental Health and Addictions to appear for no less than 1 hour each regarding the supplementary estimates A for 2024-25, and that this meeting take place as soon as possible, but no later than June 20th, 2024.
Thank you, Mr. Johns. The motion has not been provided with adequate notice, so it would normally be ruled out of order, but we can do anything by unanimous consent. Is there unanimous consent for Mr. Johns to present the motion and for the committee to adopt the motion? We have unanimous consent. The motion is adopted. Thank you, Mr. Johns.
Okay.
Go ahead.
Thank you, Mr. Chair. Mr. Chair, I'm going to ask Dr. Henry, we had seen in 2014, as I said it earlier, 7.9 deaths per 100,000, which is horrific, go to 30.3 deaths per 100,000 under the former BC Liberal Conservative Christy Clark government. The largest spike in British Columbia's history, 383% over 4 years. And we saw a similar spike in 2019 to present day under the United Conservative government in Alberta of 275%. Can you speak about what trends you're seeing, or maybe why this happened under this government, under those governments? And certainly we've seen a spike under the NDP, but it's been a far less spike. Can you talk about what trends you're seeing?
Just to clarify, I don't have any comments around what government is in power around these issues. What I've seen is that it is very much dependent on what is on the street, and that is what is leading to deaths. And so we have in British Columbia tried to take an approach that is nuanced, that looks at all of the various aspects that we need to have in place to support people and to keep them alive, whether they are somebody who has an opioid substance use disorder, or whether it's somebody that is using drugs on an occasional basis, because we know that people are dying in both of those situations.
Thank you. I appreciate the qualified response, and I do. Dr. Henry, the Minister of Mental Health and Addictions keeps saying that they're meeting the moment. This is a health emergency. Do you believe that the federal government is meeting the moment? And what could the federal government do? Because we saw how they responded to COVID-19. We were able to work through jurisdictions and respond rapidly. What is the difference you're seeing in terms of this crisis? Is it just the stigma is the barrier? Because we're seeing that, I believe, from the federal government in the inaction and the incremental approach.
I do believe that the issue of people who use drugs is cloaked in stigma and shame, and that keeps people from talking about this. But we know from data that everybody in our communities across this country have been affected by this crisis in many ways. And so it is something that I think we need to have a coordinated approach across the country. There is absolutely room for people doing different things in different communities to support their communities, but I would like to see a coordinated cross-governmental approach that supports people in communities across this country, because all of us are being affected.
Thank you, Dr. Henry. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. So I guess I will start out with Dr. Henry. Does diversion scare you? Are you concerned by diversion?
I think diversion, as I've said many times, is a symptom of unmet needs. And in the case of the unmet needs that we are seeing, it is very concerning to me. It means that we need to take different approaches. But I also want to recognize that diversion is not new. We've seen that in many parts of this country. In BC, the toxic drugs on the street has been the proximal cause of what we've been dealing with.
I just want to think. I have very limited time. So, do you think having more drugs on the street will solve an addiction crisis?
I don't think we're having more drugs on the street. What we're seeing is the toxicity of the drugs on the street has been driving this crisis.
Okay, so based on kind of rough math, there's about 50 million safe supply hydromorphone pills prescribed in British Columbia every year. How many of those 50 million pills would be acceptable to be diverted into the hands of gangs and people who are profiting off the death of Canadians?
None would be acceptable in that circumstance.
Okay. How many would be acceptable to be diverted into the hands of youth? You're on mute.
None of us want youth to be taking drugs. And we know that taking prescription drugs is something that we have seen for many years in young people, and that's often where people start.
So because of that, what has the government of British Columbia done to reduce diversion to prevent these potent drugs from getting into the hands of kids?
Yeah, that is one of the things that we need to pay a lot of attention to. So, what is it that gives young people the strength to understand what's out there, to go against peer pressure?
I understand all of that, and peer pressures existed for time immemorial. My question is, what has the government of BC done since they've introduced 50 million pills of hydromorphone, a highly potent synthetic opioid that is stronger than heroin, into the market? What have they done to prevent those pills from getting into kids' hands? Has anything happened to prevent it from getting into kids' hands?
Of course we have, and with the programs that we have that are prescribed, safer supply means that people have a prescription. They have a relationship with the prescriber to access medications. And we know that there is people who share medications, people who keep their drugs.
Do you think people sharing
for different times?
Do you think people sharing their safe supply is compassionate? We've heard that from one witness here.
I think in some cases it is. It's a symptom.
So as a medical doctor,
of unmet needs.
As a medical doctor,
people who can't access.
As a medical doctor, are you comfortable with people sharing their safe supply with another person that's struggling with addiction?
I think it is a better alternative than the street drugs that people are required to access to maintain their addictions, and that's the challenge. The challenge is that we have unmet needs.
So you're okay.
Cannot access.
So just to clarify, you think that it is fine to divert your prescribed safe supply as long as that person you're sharing it with has unmet needs? It's absolutely A-okay, even if it's a teenager, even if it's a child.
Yeah, I think you're trying to make this into something that is a scenario that is not what we're dealing with. And what we're dealing with.
But it is what we're dealing with. It's what we're hearing.
To access programs. So we do need to do better at providing people with the medications they need to get them on that road that we all want people to be on of recovery.
What is the wait time approximately for a child, 12-year-old in Cranbrook, British Columbia, to get access to detox?
I don't have an answer to that question.
Do you think it should be immediate?
Absolutely, if that child needs it.
So do you think
if
a child
needs it, they should have access to supports from somebody who is trained to understand their needs.
So
and is able to support them.
A child that is addicted to drugs that ends up in the ER in Cranbrook, Alberta, in Cranbrook, British Columbia, do you think that they should be released because there is no detox space available?
I think they need to have a relationship with a provider that supports them for their needs at that moment. Absolutely.
Thank you.
Desperately seeking help is meeting their needs?
I'm sorry, I couldn't hear that question. It was cut off.
Do you think releasing someone that is desperately seeking help is meeting their needs?
I think it depends on the situation that that person's in, and absolutely, we want all children to have the supports and the connections that they need.
Henry. Thank you, Dr. Henry. Thank you, Ms. Goodrich. Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. I would like to once again thank you, all the witnesses here with us, and thank you the work you are doing on the ground, especially from British Columbia. Mr. Chair, we know that the BC is already impacted by forest fires this 2024 season. This is why, colleagues, I wanted to use my time in this slot, in this meeting, to move the motion I distributed earlier, Mr. Chair, given Canadians and Indigenous peoples experienced extreme weather events and population in 2023, including but not limited to wildfires that occurred coast to coast from the Okanagan and Shawinigan and Tantalin area, high poor air quality indexes across the country, flooding in Alberta, Nova Scotia, Ontario, and Quebec, and industrial waste impacting communities or regions such as the Athabasca, Chippewa First Nation, Port Abitibi,
Just a second, Ms. Sidhu. Point of order from Mr.
Can we
Doherty.
have just a brief suspension to confer with our colleagues on this?
Ms. Sidhu, if you could finish moving the motion, and then I'm going to suspend the meeting to allow for a huddle. I find oftentimes that expedites things. We'll probably also dismiss the witnesses at the same time. So finish your motion. We'll dismiss the witnesses. We'll suspend the meeting, and we'll take it from there. Go ahead.
Sure. Such as the Chippewa First Nation for Abitibi, Timiskaming, and the most recent wildfires that have affected those in Fort McMurray, Fort Nelson, Council, and Vandroof. This is why I move that pursuant the Standing Order 1082, the committee undertake a study of no less than 6
point of order,
hours
Chair.
on the negative
Ms. Sidhu,
effects.
another point of order. Go ahead, Dr.
I just have just a question. If this was moved quite some time ago, is the motion the same? Because it appears there's some new information added. Am I mistaken, or?
Should I complete a motion?
Okay. Ms. Sidhu, the motion that you are moving is that the one that was put on notice on Monday, May 27th?
Yes.
Okay. I think what happened was she started speaking to the motion, and then she introduced the motion, and so it looked like there was additional information. Okay. Have you finished moving the motion?
I'm in the halfway. I'm going to finish quickly,
please finish.
Mr. Chair. I move the pursuant of Standing Order 102, the committee undertake a study of no less than 6 hours on the negative effects climate change and pollution has on the health of Canadians and Indigenous communities, including the cost of the healthcare infrastructure, resources, and impact on vulnerable communities and populations. That the committee reports its finding and recommendation to the House, and the pursuant of Standing Order 109, the government table a comprehensive response to the report.
Okay. Thank you, Ms. Sidhu. To our witnesses, we are rapidly approaching the top of the hour, which is the time that you agreed to commit to us. We're unlikely to get back to you before the top of the hour. So I'm going to take this opportunity to tell you how much we appreciate your flexibility in being canceled at the last minute and then coming back to provide your testimony in such a patient and professional manner. We are grateful and indebted to you for all of that. You are welcome to stay, but you're free to leave. Thank you so much. With that, we're going to suspend for 5 minutes to allow for everyone just to figure out what they're going to do with respect to the debate on this motion. I will say this: the motion is in order. After the suspension, the question will be on the motion. We're suspended. when we suspended Ms. Sidhu, you had just moved the motion. I'm not sure that you had relinquished the floor. So the debate is on the motion. You have the floor, and Dr. Ellis is next.
Mr. Chair, Dr. Ellis can go ahead.
Dr. Ellis, please.
Thanks very much, Chair, and I appreciate Ms. Sidhu wanting to move this motion. There's just a couple of things I think that are important to point out. One is, most importantly, today was scheduled for drafting instructions related to a study on women's health, which I think there's some incredibly significant things that, on behalf of all women in Canada, that we need to get to with respect to that study. I think that there are issues there that I think we can all agree upon need to be said out loud, and I'm not entirely sure why in this committee we seem to struggle getting through reports without having more and more motions coming forward. And I think the other issue, Chair, is related to that we really haven't had a planning meeting to try to understand better what we are going to undertake next. And just because we do have quite a few new members here, I would also suggest that historically what we have done, and I know the waters have become a little bit muddied now because of some of the studies that we've undertaken, but that being said, that we had I'll use the word tradition here, even though the tradition would really make us want to think that it's been this way for decades, but the tradition has been short. Some are long, some are short. But we have had a tradition that, that there was a study proposed by each of the different parties, perhaps in proportionality to their representation here, and then moving around in a perhaps a circular direction. So I would suggest that we should have a planning meeting, perhaps to get back to that, to really have a more fulsome look at the proposed studies that are before the committee. Obviously, if there are studies that are perhaps more urgent than others, then we would certainly, I think, talk about that as a larger group to understand, on behalf of Canadians, what we should do in sequential order. I think the other thing that's really important that I know my colleague Ms. Goodridge had put forward a study on breast cancer, which is, of course, somewhat mentioned in the women's health study, but I think, and there's more evidence that came out today, and if you'll indulge me, a recent news article put out by Global News that says, sorry, just one second, Canada's guidelines for routine breast cancer screenings will remain unchanged despite mounting pressure from medical experts who have labeled them as dangerous. The Canadian Task Force on Preventive Healthcare released its updated guidelines Thursday, recommending that people in their 40s should not get routine mammograms, but can request one if they want. The current guidelines set by the task force are to begin routine breast cancer screening at age 50. The first and most important recommendation coming out of this guideline is that breast cancer screening is a personal choice and that people deserve information so they can make the right choice for them. We recommend that women between the ages of 40 and 74 are provided with information about the benefits and harms of screening to make a decision that aligns with their values, preferences, she said during a media briefing on Thursday. She added that this information should never cover factors like family history, race, ethnicity, breast density. If someone is aware of these factors and wishes to be screened, they should be offered mammography every 2 to 3 years. The task force said it holds firm on its position not to lower the recommended, there's obviously an error there, age due to concerns of overdiagnosis and unnecessary biopsies. The new breast cancer screening guidelines released today by the Canadian Task Force on Preventive Healthcare are dangerous and harmful to Canadians. Dent Press Canada Executive Director Jenny Dale said Thursday, "We're beyond disappointed in their recommendations. The guidelines should reflect the latest evidence and prioritize the lives of Canadians. The task force has failed us, and we ask Canadians to tell Minister Holland to suspend these guidelines and use modern science to save lives." It does go on. People talking about they're deeply concerned. There's good evidence. The guidelines are outdated and flawed. I'm just paraphrasing to try to speed things up here a bit. That the guidelines are outdated and flawed.
Que les lignes directrices posent des problèmes. Rappel au règlement, Monsieur le Président. Order.
What's the point of order?
Yeah, I don't see how Dr. Ellis's speech is relevant to the motion on the table.
Thank you, Dr. Hanley. As I was listening to Dr. Ellis, it seemed to me that he was pointing out that there is other studies that should take precedence over this one. He got into an unnecessary amount of detail with respect to his choice, but I don't think he's that far removed from the point that it is entirely irrelevant. But if you could bring it back a little bit, Dr. Ellis, go ahead.
Yeah, absolutely, Chair, and that's why as I began down this road, I started, the article goes on and on, didn't realize it was quite so long. The point is, of course, is this is information. I think there's two really important things, that this happened today, and the second thing is this article points out that, if there's any avenue in this country to get this incredibly important issue into the mind of the Minister of Health, as it references in this article, that it underlines in this article that we are the closest people, physically and from a loudness of voice perspective, to get that information to the Minister of Health, Mark Holland. So that being said, this is an urgent issue, which we've already had on the docket previously, which does relate specifically to the drafting instructions that we were to get to today. And I just can't understand, we got into this problem before in this committee where we had a first of all, we had a health human resource study that got backed up for, I want to say it was over a year. That's a disservice to Canadians. And then we had a children's health study that we had so many different members here that in the end, I think there were, I don't know, probably 3 or 4 or 5 of us perhaps who were here for the majority of the testimony related to that. And of course, trying to create a report that is any way, shape or form useful on behalf of Canadians when the majority of people were not even here during the report to hear the testimony becomes very, very difficult. And I think too that when we talked about this previously, we had talked about trying to clear some of the backlog of issues that we'd had, which using the half an hour that we had today would have made perfect sense to do that. And then, as I said, to have some planning meetings around looking at the other topics that are of critical importance to Canadians. I'm not saying, Ms. Sidhu, that your motion is not of critical importance. Perhaps it is. I think perhaps hearing it again would be useful. I think our minds were significantly turned by another issue that's of critical importance to Canadians right now, and unbelievably topical since the federal government was involved in a partnership with the BC government for an experimental decriminalization project with respect to opioids, which is killing more than 22 people a day on average. You all know that. And so I guess I can't understand why we're focused on that particular study. That study wanted to be interrupted. I can't understand why when we had significant witnesses here.
Point of order for Mr. Johns, please.
There is not 22 people in British Columbia dying a day from toxic drugs. Just to clarify.
If I said BC,
Mr. Johns, it isn't a point of order. It's a matter of debate on something that isn't particularly relevant to the motion. Go ahead, Dr. Ellis.
Thanks, Chair. To be clear, if I said in BC, I misspoke. In Canada, you're very welcome, Mr. Johns. Yes, 6 a day in BC. So anyway, that being said, back to the point here is that we're not making a useful and judicious use of the limited time we have. We also have another motion, and I'll take my hat off to Mr. Johns that he presented his motion, which was germane. He presented it quickly. We agreed on it quickly. We moved forward with it because it too is incredibly important that before the end of this session, that we are in a position to have the ministers respond to estimates again. So my plea to this committee is that we have work before us, some of it perhaps more important than others, some of it's, and this is my summary, Chair, just to give you a heads up, that some of it is incredibly important on behalf of Canadians, perhaps some of it less so, and I'm not going to be telling you that I think I'm the arbiter on that, but also the fact that we have a bit of a backlog of things that we need to get to, and we are coming towards the end of the session. Now, if members have that desire to sit all summer and have Standing Committee on Health meetings all summer, I think that the Conservative side is quite happy to do that. So if that's your plea, Ms. Sidhu, I'm happy to be here to do that and to be of service to Canadians. I think that that's incredibly important. And I think specifically with the study on opioids, and again, this is my own prioritization, the study on opioids and the study on breast cancer specifically and screening guidelines, for me would be at the top of my list of things that we need to do on behalf of Canadians. And because of the dire straits, the difficulties that we got into with respect to other studies in the past that I think, and this is not through the fault of the analysts, not what I'm meaning to say in that direction, but in the past we've got into some difficulties with the studies because they've been so prolonged and drawn out that causes extreme difficulties and makes reports with all of our names on it that are perhaps not as good as they could have been if we did them in a more timely fashion. So that's my plea, and for that reason, I move to adjourn debate on Ms. Sidhu's motion.
Motion to adjourn debate is a dilatory motion. It is not debatable. We must go directly to a vote. All those in favor of adjourning debate? Hands, please. 1, 2, 3, 4, 5. All those opposed to adjourning debate? 1, 2, 3, 4, 5, 6.
Chair, I'd like to request a court of division. There's just too many people who are online for me to process that. So if we could ask the clerk to do a
Don't need a reason. You can have it as a right. Court of division, please, Madam Clerk.
Thank you, sir. So to adjourn debate on Ms. Sidhu's motion, Dr. Hanley.
No.
Madame Kayabaga.
Contre.
Madame Brière.
Non.
Dr. Pawlowski.
No.
Ms. Sidhu.
No.
Mr. Doherty.
Yes.
Thank you. Dr. Ellis.
Yes.
Ms. Goodridge.
Yes.
Dr. Kitchen.
Yes.
Madame LaRouche. Merci. Mr. Johns.
No.
6 nays, 5 yeas.
The motion is defeated. Ms. Goodridge, you have the floor.
Thank you, Mr. Chair. It's really frustrating, and it's just one of those things, but to just kind of go a little bit further, and I appreciate Ms. Sidhu bringing this motion forward, but it's really frustrating. We had possibly some of the most powerful testimony I've heard on this opioid study come from Mr. Earl Thiessen when it comes to his own personal lived experience with addiction. And the fact that we decided, because there was a motion moved to not continue having questions to him, I think is, and to the other witnesses that were here, is extremely difficult. Also, Mr. Chair, there's a lot of conversation happening in the room, and I'm having a hard time hearing myself think.
Thank you, Ms. Goodridge. Could I ask everyone just to extend the courtesy to Ms. Goodridge and to your colleagues that when they have the floor that you keep your side conversations outside? Go ahead, Ms. Goodridge.
Thank you, Mr. Chair. And to just follow up on some of what my colleague, Dr. Ellis, stated, the motion that I had moved on looking at the breast cancer guidelines isn't just politics for me. This is something that is incredibly important to me. I was 21 years old when I lost my mom to cancer. And my mom was 49 years old. She was 49 years old. She was younger than what she would currently be able to get a mammogram for. And in the time since I've lost my mom, and that shook our entire family. That created trauma, that created heartache, that created so much challenge for my entire family. I remember watching my dad, who was the strongest person I ever knew, turn into a very broken man for a while after my mom died. That was the love of his life. And it was breast cancer. It's something that should have been completely preventable had she simply been able to have adequate diagnostic testing available to her at an appropriate age, at an earlier age. And the Canadian Cancer Society, in fact, today put out a statement. The Canadian Cancer Society is, and I quote, is disappointed by the new breast cancer screening guidelines released today by the Canadian Task Force on Preventative Healthcare, and specifically the lack of recommendation to lower the start age to systematically screen for breast cancer nationwide. These conversations happened as we were studying the women's health. We heard from multiple witnesses about the importance of breast cancer screening earlier, about the difference between breast cancer screening when it comes to dense breasts and different breast compositions. We heard a lot about women's health, and it was something that hit me as someone who is the daughter of a breast cancer person, that it hit me that we could make an actual, real, immediate difference in the lives